Hello, and welcome to Conversations with Sara. Today's topic is going to be normalizing operations. And yes, I use the word normal, and I know it's problematic. I've been thinking about this for a long time, but it's the best word to use. And I know for some people, they hear normal and immediately they think we need to get back to life 5 years ago, before all this happened. And we know that's not feasible, that isn't going to happen. So as leaders and motivators, I feel it's our challenge to help others begin to normalize and adjust and adapt to the environment that we're in now. And as I've been thinking about this video, an analogy came to my mind, and I think it suits kind of what we've been through very well. As I have worked since COVID began in 3 different health systems on both sides of the country. I've also been, keeping up with nurse forums and talking to my colleagues. So I know that this pattern sort of happened all over the country here in the US, and I'm sure it happened outside of this country as well. So my analogy is when you have to move unexpectedly. So you're home or you're in your apartment and everything is set up just the way you like it. Everything has its place. You've got your routines to do the things that you need to do on a daily basis. And then all of a sudden, out of the blue, you have to move. So all your things get thrown into boxes and you hurry over to this new place that you have to go. And it doesn't look or feel like the old place. So for a while, you are living in this chaotic, frantic state of needing to do your activities of life, but not being able to find anything. You're rummaging through boxes, you're trying to figure it out, and it's kind of a churning, chaotic state. Eventually, you reach a point where everything has been taken out of the boxes and put away in your new place, and you establish routines that will work for where you are now. And that is what we need to get to today, because we've been churning for far too long. And this constant churning and this constant mindset of, well, we're in a pandemic, so we can't have a committee meeting, or we can't hold staff meetings, or we have to put evaluations on hold. All of those thoughts, that mindset is going to lead us down a path of destruction. We're going to lose the ground that we have made and created in our institutions across this country. So it's time now. And we as leaders have that challenge to bring people thinking, how are we going to get back to normalizing operations? So, it's important. It's important for staff to have an opportunity to come together in a meeting, whether it's virtually on some sort of a software like Teams or Zoom, and talk to each other, or have one-on-one conversations with their managers doing touch base and evaluations. It's important for our patients for us to do rounding, to make sure their scan is intact, to make sure all of the safety equipment and things are there. And I know that to some extent these things were being done, but not consistently and not the way that they had been done. So for those of you who watch and listen that haven't been in healthcare or haven't been in a hospital in a while, you may have seen the headlines and seen what's going on in social media, but don't really understand how we got to this state. And how we got here is certainly a very good question. It's one that I think people are going to talk about, research for years to come, because it's going to play out and be a bunch of little tiny factors all coming together to make this perfect storm, as well as some great big things that happened. But I think it's fair for us to kind of look at it and see some of the contributing factors, so that everyone can have an understanding of why healthcare, especially here in the United States, was taken so off guard, and why we fell into this chaos of being that we're currently in. Now, my disclaimer will be, healthcare in the United States is not a perfect system. It actually needs lots of reform and renovation. Pandemic did cause cracks in the system to become chasms. But prior to this pandemic, hospitals had done a pretty good job of mitigating disasters. And I say that because you don't see it in the news, and you don't think about it when you see a mass casualty event, like during the Boston Marathon, things that happen, a train derailment or anything that creates mass casualties. You don't think about that the health system, that the hospitals are handling that. They're taking care of these patients, treating them. You also don't see in the news how well hospitals do with evacuating prior to fires and those kind of things. What you do see in the news and what does make the headlines is the times when we fail, like Hurricane Katrina, or I remember those 6 tornadoes that hit Missouri. Those make the news because bad news sells. But for the most part, hospitals always did a pretty good job of handling emergencies or handling disasters. And that's because we routinely planned for them. We had drills. And those drills could take the form of a tabletop, going through scenarios on pieces of paper, to a full-blown multi-system regional reenactment with role players and everyone getting involved in creating this simulation of a disaster. So we knew who our resources were. We know how to set up a command center. We know how to put those things in motion. And certainly on the list of disasters that we participate for, global pandemic is on there. Weather emergencies and mass casualty traumas like a plane crash or a car pileup on the road or an act of terrorism. Those are always the big things you think of, but global pandemic is on there. And we traditionally had a government agency that would provide us with guidance that was science-based, fact-based, that would collect data and come back with good, strong guidelines for how to handle infectious processes and things that came along. And this government agency was called the Center for Disease Control, CDC, in Atlanta, Georgia. And they were who we turned to. They were our guidepost. So we had these things in place. But prior to this virus coming across to our country, a few things happened. One, we had a president in DC who, and I'm trying to be very careful, who tried to disrupt the status quo, and actually did go a long way disrupting the status quo. And one of the ways in which he was doing that was appointing people to head agencies whose values and reputation were in direct contrast to the agency that they were appointed to. And this is something that you could look up on your own and see a lot of a long laundry list of examples. And I won't go into those. I want to focus on the CDC. Again, you can do more research about who was appointed to run the CDC, but I'm just going to give you an overview of some of the facts behind it. The first was a woman named Dr. Fitzgerald, and she had very strong ties and connections to the Coca-Cola company. And if you don't think that's problematic, then, she didn't last very long. The second one was Dr. Redfield, who was a military doctor, and he has close ties and associations with fundamental Christian groups. And these groups and his strong fundamentalist beliefs drove policies and practices that he had back during the AIDS crisis. So the way that the soldiers were treated during this crisis under his watch is very controversial. Again, something else that you could dig a little deeper into and look up for yourself. But needless to say, these two appointees back to back created some chaos in the CDC, and they lost a lot of their good people. It also caused it to be a more political agency. And then the pandemic comes to us. And in DC, it was dismissed and downplayed as being a minimal thing. It will be over by Easter. The CDC's ability to collect data from hospitals was undermined and taken away from them and turned over to a third-party private agency in Pennsylvania. Now, someone's going to dig a little deeper and find out exactly what that meant, the consequences of that. But what we do know is that the CDC no longer had the ability to collect data from hospitals in regards to the coronavirus. So, hospitals, here we were. Sick people were coming through our doors and dying. And we weren't sure what was going on. And we weren't sure how to protect ourselves or our other patients, how long this was going to last. And looking for guidance, it wasn't there. The CDC was sending us conflicting information, and different things throughout the course of a day sometimes. The hospitals did what they always do, and they set up incident command, and they started following their emergency management practices. And when you set up an incident command and follow emergency management, then communication becomes strictly top-down. And because of the nature of this virus, everyone was going into lockdown. And so only clinical people were in the hospital working. All the non-clinical support people that you had were working from home. Meetings were canceled. Committees were canceled. Projects were put on hold. Everything was stopped. Units within the hospital lost their identity because they had to switch and become a COVID unit. So their patients got moved to other units, and temporary MASH setups were placed in basements and in shell spaces to handle the surge. Because no matter what was churning, no matter what was going on in all the government houses around the world, patients were still coming to the hospital and dying. We were running out of supplies. We didn't have enough ventilators. Leadership wasn't there on a national level. Leadership to declare a national emergency that would have triggered these supplies being sent out to where they needed to be. Instead, we had governors reacting in different ways depending on their politics. So everything became political. Public health and safety took a backseat to your political beliefs. And that is what helped just keep us running in circles. Whether or not to be vaccinated is a debate that I'm not going to get into in this video. But I will say that we, the world, lost our chance to eradicate this virus. That door is shut and locked, and that opportunity is not coming back. We will not be able to eradicate this virus because we couldn't get enough people vaccinated. So having unvaccinated people in our population meant that the virus could do what the virus does best. Viruses are living things, and they find hosts to live in, to mutate and continue their survival. Because we had so many unvaccinated people, the virus had plenty of opportunity to mutate, and it did. And the patients kept coming, and the patients kept dying. And today, I'm not going to give you a solid number because it changes, but we have over 900,000 people in the United States dead from the coronavirus. Very close to 1 million. That's the facts. So this lack of stability, this lack of leadership, this lack of clear guidance, the hospitals were responding and doing the best they can to try to treat as many patients as they can, to do what they can to lower and mitigate the risk involved for everyone. And that authoritative emergency management style does very well in a short-term setting. But now we have to face the reality that this is a long-term virus. This is something we're going to have to learn to adapt and to manage as part of our daily functionality. And that's very similar to HIV. We had to learn how to manage HIV because it's not going anywhere. It hasn't gone anywhere. But we were able to work and develop and come to grips with how we can manage HIV. So the same thing with this virus. We need to shift our way of thinking and get out of the crisis mode. And that leads me back to, now that we have unpacked the boxes, the chaos is still going to be there for a little while because surges may still come. We don't know what variants might be cooking out there, if any other variants are going to come and wave across the world, like Delta and Omicron did. But we still have patients who aren't infected by coronavirus. And we have hospitals, and we have to run our business. So shifting that mindset from we're in a crisis and we can't do anything to, okay, we need to get back to the basics, is something that we are challenged to do as leaders and managers and directors in facilities. And so, I think we're starting to see a reemergence in things. I think it's very important for us to be part of that, to lead that, to lead by example and start meeting with our team again, recruiting again, conducting interviews, bringing staff on. You got to think too, one of the things that this virus did when it comes to nursing, we lost a lot of nurses. I don't know the number off the top of my head, and I think it changes, or it's not as reported as widely as it should be, but we lost a lot of nurses due to this virus for a variety of reasons. But one thing that I keep in mind is, if you left the profession because it was getting too tough to handle, then you weren't in it for the right reason. And maybe you're better off being out of nursing, and nursing is better off finding someone else. And I say that, with respect for people who choose to leave, because I'm glad you realized it and moved on. That leaves nurses who are dedicated to the patients, who are in it to be nurses. They're not in it for a stable job. They're not in it for a decent paying job, which is how a lot of nursing schools would advertise themselves. Get a career in nursing because you'll always have work. That's not a good reason to get into nursing, because nursing is a hard job. It is an extremely difficult job. Nursing, respiratory therapy, physical therapy, any of the healthcare professions that deal directly with patients is difficult. It's emotionally draining. It's physically draining. So you have got to be in it because it's a calling. It's something you're driven to do. These new grads who have gone to school during a pandemic, and the nurses that are still here, the CNAs that are still here, the therapists, everybody that is still here working at the bedside, it's because they want to be here to take care of the patients. And that's something to celebrate too. And you need to show your appreciation as a leader, one-on-one, and be sincere with your staff. I think we will get there. I think we're going to get on the other side of this stronger and better as a profession. I think we are seeing the cracks, and hopefully we can figure out how to get past them and how to improve the healthcare system in our country. But a good start, grassroots, is in your own world, in your own unit, getting some things back to where they need to be. Having your staff feel that they have a voice and that they can bring ideas back through committees, through unit-based council, through shared governance, whatever you call the meetings that you have that the staff can lead and direct. That's what we need to get back to. Rounding out our patients, looking at our patient's skin, talking to our patients again. Those are things we should get back to. And we will be on better ground once we do that. These are my thoughts. These are my where I'm at this moment in my career. And I just wanted to share that with you. If you have thoughts and ideas of your own that you would like to share, please do so in the comments. Please let me know. And until next time, take care.